both of you, Udi Maor and Evre Raspaldo. Let me say a few words about Dr. Raspaldo. Dr. Raspaldo had training in France and in ENT and maxillofacial surgery. Then he completed another 2 years with doing facial plastic surgery, and he's been doing that for many years. He's very well experienced in surgical and non-surgical facial plastic surgery. And I thank you for joining us this evening with Dr. Udi Maor, who is a board-certified plastic surgeon in Israel and works as a senior surgeon in Soroka Hospital. So what we'll do today is that Udi will talk about 20 minutes about his approach to the men face. And after that, Hervé, you will discuss your approach. And after that, we'll have cases, and each of you will say his opinion. I'll also invite all the participants. We have now 71 attendees. Each of you can bring cases and present them. That could be very nice. Okay, so Udi, I suggest that you start.
All right, thank you, Meir. Good evening to everybody. I hope that everyone are well, in good shape, and return quickly to our work. I have a private practice in Be'er Sheva, and a large scale of it is based on toxin and filler injections. And today I would like to show at least my approach to man face and sculpting with stillage line of fillers. A disclosure, it's a non-sponsored presentation. It's all about teaching, but I'm a Vivacy and Mills instructor. I use other injectables in my practice. And for this presentation, I included photos from Vivacy and a wonderful video illustrations done by Dr. Nimrod Friedman, who is a colleague of us a few years ago. So thank you, Nimrod. And all the other, or my photos are with informed consent. So let's start a little bit about statistics. The American Society of Plastic Surgery issue every year reports on cosmetic practice. Here we can see the female cosmetic minimally invasive procedures in 2018. And we see that 2.4 million women underwent soft tissue fillers. Well, this is a nice number, but when we compare it to the male patients, we can see that only 100,000 soft tissue fillers made for men. And actually, it's a nice number, but nothing compared to the other gender, and we hopefully will be catching up in this area. The rise is impressive, though, because we can see that 30% rise in male cosmetic procedures from 2000 to 2018, almost 20 years, so 30%, and 70% rise in all minimal invasive procedures, which is quite of a comfort, and it shows that men are seeking more of these kind of treatments. What about in Israel? Well, our society issue also statistic every year. In 2018, we had 12,000 cosmetic procedures and 2,100 HA for male. And in 2019, we have almost 500,000 total aesthetic treatment, almost 1,300 per day. Among these, HA fillers is a total of around 80,000 for both men and women. And for the men, it's a good ratio. It's almost 20% rise of about double the last year. So it's a nice rise. What we'll see in 2020. So hopefully it will get better and it will be as impressive as the last years. But of course, the corona pandemic will probably influence significantly on our practice. People will have less resources. They will reevaluate their priorities. But of course, we have to be there and hopefully to get out of this crisis. So hopefully, to keep these proportions when we get out of this pandemic and not these ones, as we've seen a lot of funny pictures lately. Anyway, the themes or the topics of this lecture will be the terminology of beauty and male facial aesthetics, differences between male and female facial anatomy, aging process in men and rejuvenation with stillage line of fillers, do's and don'ts and how to avoid mistakes. And our guest from Switzerland, Dr. Raspaldo, will comment on profiloplasty, non-surgical rhinoplasty, jawline definition or the Texas jaw, and of course in male patients, according to his vast experience. Now, beauty in nature is quite common, quite similar to men. In the mating season, the male beautifies and tries to impress the female. I think it's quite similar. And the beautiful and symmetric male is more genetically compatible, physically attractive, strong, resilient. In humans, the beauty was described and characterized by a lot of methods or systems, but basically one of the more famous one is the ideal proportion, which was described a lot of years ago by the ancient Greeks, the Romans. It's actually the golden ratio, the phi number, the 1.6 number, which we can apply to almost everything, even without knowing that we do that. And what it means for the face is that it's a perfect ratio. The perfect ratio of the face is supposed to be a length and width of a 1 to 1.6. Sorry, the length 1.6 and the width is 1. And we see it in art, we see it in sculpturing, we see it in ancient Nefertiti, we see it in the beauty masks, or how to apply symmetry to the face. And according to this number ratio, we can see what happens if we deviate from that golden ratio, and caricatures are a good example for that. Now, in the last decade of male beauty and fashion, if we start from the 1900s, first men were strong, masculine, then it became elegant and started growing mustaches and beards, military looks in the Second World War, and then the 70s, more sexuality, more freedom, more rebellion kind of look. And on the new millennium, we found a new men or fashionable men, which is the millennials. This is a very important breakthrough or point in time, because these are men that are getting close to metrosexuality, or they are metrosexuals, they are better educated, they have higher demands and expectation. And the last years, the hipster or the so-called careless, clean, sophisticated look came into fashion. So, and we can see the changes, but basically in the last year, the ideal man or the ideal proportion of 2010 is this actor. This is the most handsome actor in the world. This is a work done by a plastic surgeon who took the golden ratio and applied it for certain stars and Hollywood stars. And of course, it's a non-standardized pictures, and there's not a lot of serious research about male beauty in the internet, but still there is the power of film stars and social influencers and advertisement. So the main feature, what we see, which is common to all of these men, is the frontal bossing and the supraorbital ridge, resulting in deep set appearing eyes. We see a flatter and narrower eyebrows. Eye opening is narrower. We see a slight longer or wider nose than female patients, and a thinner lips, especially the upper lip. which is very important to keep on this ratio. We'll see it later on. Last thing, and a very important thing, are the square or angled and larger jaws. So according to this ratio, we calculated it, and you can see the results. George Clooney was the leader a lot of years, but probably because of aging process, he went down the list. What are the gender differences when we talk about skeleton, skin, and all the soft tissues, fat pads, and muscles? So in the skull, we have thicker, heavier, larger skulls. We saw, like in the slides before, the more sloping forehead with the frontal bossing. This is contrast to the more vertical in female. We see that the supraorbital margin are sharper in females and more ridged in men. We see that the zygomas are thicker, heavier, lower. And we can see that in the chin area is more squared. The angle of the mandible is more acute, almost 90%, and projected laterally. So it's a wider jaw. Keep that in mind. I have here a very nice video. I hope it will pass through the internet connection properly, but you can see slowly how a woman face becomes a male face. And I will try to play with it a little bit so you can see how it turns and what are the basic facial skeleton features. Did you see that, guys?
Yes.
Is it okay?
It's very nice.
Nice. Now, the facial skeleton resorption also, of course, affect male, and it's quite the same as female. We have a lot of resorption in these arrow areas, and we can see that in the great work of Mendelssohn. He shows us how the orbits get widened and how the piriform angle becomes more acute with aging. The glabellar angle becomes more acute. This is a key feature when we want to rejuvenate males because we have to think about this medial cheek or the nasojugal groove. Surprisingly, the jawline and the chin doesn't resolve much. They quite stay the same, but still we have some resorption in the anterior chin. What about the skin? In the male patient, we have thicker epidermis, around 15 to 20% more, thinner subcutaneous fat, or collagen fiber density, and that makes the male skin more elastic and with higher turgor. They have more sebaceous glands, so we have higher moisture, more oily skin, and that actually makes us with less superficial wrinkles compared to women. And we have this special arrangement of crossed via the vertical collagen bonds, and it basically a tougher deal to lift. Because think about if the hyaluronic acid molecules push the tissue upwards, it resists much more with the male patient because of this X network. So keep that in mind, and we will have to use a lot of times more material and more superficial or in the sandwich technique. Now, we all know about the sagging, loss of volume, changes in fat compartments, but basically what is important to understand is the superficial fat compartments and the mid fat compartments gets atrophied and sag. In the forehead, it accentuates bony projection or concavities and produces, for instance, the temporal hollows. In the orbital, it produces atrophy of the orbital fat over the inferior orbital rim and pseudo-herniation of the orbital fat pads. In the midface, atrophy and redistribution of fat with the medial malar fat pad, which descends, and the nasojugal and nasolabial creases become more prominent. Now, if you see here the nasolabial fat bed, it doesn't get atrophied much. It just keep hanging on the nasolabial fold. And when a male patient comes to our clinic with this kind of fold, it's very hard to treat. We'll see it later. Lastly, in the lower face, we have redistribution of the jowl and the jowl fat, actually, to a formation of a bulldog or a sagging jowl, the pre and the post jowl sulcus. The deep facial fat pads also play a role. It's, of course, not for this 20 minutes of a lecture, but we have also atrophy and descent of these deep structures. And what all holds these fat pads intact or in place are the ligaments of the face. And we all know that these structures are like anchors that comes from the bone, from the dermis to the underlying mass. So the ligaments that comes from the bone and attach the skin are the osteocutaneous. Those are the true ligaments of the face. And these are the orbital, the zygomatic, and the mandibular. And these are the main ligaments that we have to also think about, because these areas, the orbital area, the zygomatic area, nasojugal groove, the mandibular area are the most important in male patients. Now we have the false fasciocutaneous ligaments. These are also important, but again, the true ligaments are the ones that sag the most, and we have to think about it in the injections. You can see here drawing of some true and false retaining ligaments, and you can understand why it's like a glue or an anchor to the deep tissues. Now, here in this illustration, you can see that it's quite the same. Men sag the same, and with time, we can see that all this mid-cheek area, all this orbital widening and creation of tear trough, nasojugal groove, nasolabial ligaments, marionettes, and of course, when it's in this kind of severity, there is a maximum that you can do with the syringes and with fillers. Although I have to say that also in my practice, a lot of patients, I can still find a way to improve them without sending them automatically to a neck or a facelift. So they will come in a later age. So what to do? How do we treat? How do we apply this anatomy to our daily practice? I call it the first and the second stages, 2 stages when we diagnose and we think about how to rejuvenate. First is the scaffolding stage, where we want to define the basic male facial characteristics, and especially thinking about the orbital area, the zygoma and the jawline, as I said, compared to the ligaments. We have to treat asymmetry, very important. Everyone has asymmetry. Everyone has some sort of microfacial, hemifacial microsomia in some spectrum, or some even facial nerve weakness. So we have to think about it when we do something more superficial, or even before defining the basic facial characteristics. And finally, I also do in that stage deep volume restoration. Okay, so the second stage is the color and finesse stage, where we actually go a little bit more superficially, and then we have to treat medium to superficial static wrinkles, touch-ups to the deep wrinkles or deep volume that we treated in the first occasion, or maybe in the same occasion, but we have to, in my reckon, to spread the meeting and to at least let the first scaffolding stage ease and heal, and then after 2 weeks or 1 month, I do the other stage. And of course, skin improvement, skin boosters by Hydromax, Hydro, these are the products of Stillage, But I also apply today mesobotox treatment, which is a very, very nice thing that I learned. And 8 units of Botox, I dilute it in 1 cc of a skin booster syringe, and I treat the accordion lines, I treat the lateral cheeks, acne scars. It produces great results. And if needed, of course, I refer to peeling, laser, and therapy. I admit I don't do that, and I don't have any experience with the...
Udi, could you tell us how long does the mesobotox last?
Well, it's a good thing to, it's a great question though. It's a good thing that it correlates with the Botox, time, half a year, 4 months, because also the skin booster material, you have to repeat it after 3, 4, 5 months. And I have a few patients that I try to do only the Botox treatment. And when I turned to the mesobotox, that was the turning point. And since then, I just almost in a very dry or even in every skin that I think about skin boosters, I apply this mesobotox. And of course, it's 8 units, it's not much, but it produces great result, especially to these wrinkles lateral to the nasolabial folds. Now, the main goals and principles when I start the consultation is to listen, look, feel, touch the patient, take pictures of the patient and show him the pictures, show him where the problem you think he needs treatment, and of course correlate that to the wishes of the patient. Be fair and square, don't round, don't feminize. We don't want the same principle injection as we do for female. And of course, you can improve a look by that if you keep the same principles, but you will see the differences are quite big. And leave some dynamic and defining wrinkles. We're not supposed to make men smooth. It's not, I think, an ideal beauty for men. And when a man comes for treatment, usually come when the wrinkles are quite deep, because the awareness and the society of how you're going to inject something and the shame. So when they come to us, they have already quite severe wrinkles. Of course, if they start early, it's less, but it improves with time. But still, we have to leave some defining wrinkles in the face. And of course, to choose the right filler for a specific zone. So there are so many HA fillers in the market, and every webinar talks about a new product and a better product. And I'm not saying that Stillage is the best product or the Restylane or Juvederm, but it has a very good safety profile with low endotoxins, proteins, and residual BDDEs. Also, Stillage, or let's say Vivacy Laboratories, added to their product sorbitol and mannitol, and we'll talk about this later on. And you can see that the Stillage product is a 3rd generation hyaluronic acid. If it's compared to the 1st generation, the 2nd generation of the Restylane or the Juvederm, of course, other companies have 3rd generation products as well. But the nice thing about it is that it's X-linked or cross-linked by 3 phases. And what I mean by that is that Stillage took and patented a so-called IPN-like technology, where they basically mixing 2 monophasic hyaluronic acid with different properties. One is a low elasticity property, and one is a high elasticity property. And this interpenetrated networks, this combination, they do also an interpenetrated networks under pressure, which makes the product an overall monophasic product easily injectable, and a longer lasting product. אתם רואים את החץ הגיא? Do you see the arrow?
כן, כן, רואים את זה.
All right. And as I said before, they added also to this unique and high-tech combination mannitol, which is a powerful antioxidant approved by the FDA, and sorbitol to the skin booster line, to the Hydromax, because it's a highly hygroscopic and also an antioxidant agent. And also for the new XL and the XXL properties, syringes, you can find also a combination of hyaluronic acid with mepivacaine, which is instead of lidocaine, because it produces vasoconstriction rather than vasodilation. In low concentration, 0.3, I remember, mepivacaine is produced vasoconstriction, which is better when we do superficial injections, less bleeding, less hematomas. These are the products of stillage. This is the line of stillage, and we can see it's very easy. It's like clothing, small, medium, large, XL, XXL. The special lips is a nice product aimed for the lips. I use it mainly for elderly patients, for patients that don't want extreme lips or Instagram lips. And it's a very smoothing, good agent. We have also the skin booster, two products. One is the Hydro with the mannitol, and one is the Hydro Max with the sorbitol. The Hydro is a non-linked, X-linked HA, and the Hydro Max is X-linked, which means that the Hydro will be more hygroscopic and will resorb more water. And the X-linked will do that also. It's a combined product, but less, of course. That's why they added the sorbitol. Now, the working horses of male patients are the XL and the XXL. This is most of the product that you use for male patients, but I also use medium or small for the tear trough, large sometimes for a non-existing lips, and for marionettes. So you will see immediately some examples. Like all the other materials, you can see the duration of the action, and you see the concentration, XL 26 milligram per gram and 21 milligrams for the XXL. Now, a nice thing about this illustration is it shows us where to inject all the products. And this is, of course, logical and very, you should keep on to that planes, although I have to tell you that with more and more injection and an advanced injector, we'll use these materials wherever he wants, and also the XSL a little bit superficial with the right slow, small linear threading, massaging. You can use this product and don't need to fear lumps and bumps and granulomas, at least not like we see with Radius or with other older material like the sub-Q or even Perlin. Now, I like to use cannulas. I started my practice and I was taught to use syringes. I change almost most of my practice to cannulas, and it's almost 95% of my injections. I use all sorts of cannulas, but I like most the soft fill for two reasons. This red dot, you see it here, it guides you where the opening of the cannula is. And it's a very important thing when you inject. When you compare it to other cannulas, for instance, the TSK, which are very good cannulas, they don't have such a clear mark. And you can see it even if the cannula is turned upside down. I also like this kind of a guide that comes with the cannulas, and they are also coated with a so-called soft gliding materials, so makes the difference. I have to say that they are softer cannulas. They bend more, but when you know what you're doing, you should control it. And this is one of the reasons why I changed also from 27 gauge and 25 gauge more to 22 or even less or bigger gauge cannulas. I use superficial injection points. I like this point a lot because I think it's approachable for a lot of regions in the face. And of course, you can use other points. I'll show you other points as we see in this picture. So let's now talk about specific areas. Forehead and eyebrows. What are the do's and the don'ts? Well, you can see here this frontal bossing in a male patient. This is all what you need to achieve. You don't need to raise the lateral eyebrow too much. You don't need to lower it too much by over-injecting. Just need to recognize when it's empty or when you don't have this frontal bossing and to recreate it. And of course, I always use toxin in the forehead and the profit, but I use it cautiously in male, although I use more than women. What it means is that I try to course, avoid lifting the lateral eyebrows by injecting to the crowfit above the canthal line, but I do use much more than women for men Botox, especially for those, of course, that come with severe wrinkles. Here you can see an illustration of how to inject to the eyebrow. This is a good entry point. I use a cannula, but you can do it also with a needle. It's safe. It's on the bone. This is a video on the woman. Again, Nimrod, thank you. It's a great video. And you should watch always the level of the eyebrow comparing to the upper orbital rim, because you don't want to raise it above it. For the temples, sorry, this is an example, Vivasi, famous photo. I think he was is like a model of stillage, and you can see here that he has a little bit over injection to his lateral eyebrows. I don't know, maybe some of you guys like it, but I find it a little bit feminized when we over inject it. So I think there was nothing wrong before. So watch when you do that. The temple area, also for that, I did a shift in my practice because I always used to inject to with the shotgun technique. And with the shotgun technique, you basically enter at 90 degrees with a sharp needle on the bone, and you inject under the muscle and under the fascia, the deep fascia. And that's the problem, because you try to lift a very hard structure and it doesn't do much, even if you use 1 cc. That's why I inject subdermally and I use a cannula. I go to the anterior part first, but sometimes I fill all the eyebrow. Depends, of course, on the amount of material, but usually I use 0.5 to 1 cc. And for thick skin, I use extra large. For thin skin, I use the large. And expect congestion of this area. Expect a Venus drawing on this area, but it will go away, and you can comfort the patient that with some massage, and with time it will go away. So that's a very nice area to treat male, but avoid the roundness due to over-injection of this area. So start small, even if we have to add one more syringe in the next appointment. All right. Just a second. Yeah. The cheekbone definition. Well, if you take home messages from my lecture, you should take this area, this cheekbone definition, and we'll see immediately also the nasojugal groove. Here, inject supraperiosteally if I'm in the mid-cheek to define it better. And here I inject subdermally, only for the lateral zygoma enhancement, when blending into the surrounding area. I use bolus in these points, like the MD codes of Allergan. I don't massage this area usually, maybe a little bit. But here I do a linear threading and a cross-hatching injection. And you can also notice that when you treat this or define the cheekbone better, and if you treat the nasojugal groove, you will see a disappearance of the tear trough, because some of us may think that, okay, let's treat the tear trough. Let's solve it with half syringe, half a cc here and half a c on the other side, but it will not work. You have to improve this negative vector that occurs with age. You have to fill this area. Don't worry, it's not going to be feminized. If you over-inject laterally, that's going to produce a feminine look. The tear trough area. I use only the cannula, the 25 gauge. I also shifted from 27 because it was too sharp for me and it's a highly vascular area. And under the tear trough ligament and the orbicularis, the material I use the most is stillage medium. But I always ask the patients, do you swell in the morning? If they do swell in the morning, I go to S, or maybe a little bit under correction with the M. And if they don't swell, I usually use the N. Don't forget when you inject there to not to neglect the lateral lid cheek crease, because you can solve tear trough usually with 0.5 and 0.5, but if you don't have nothing left in the syringe, then you don't coordinate it with the patient, he will be disappointed. So I always say that sometimes you need more to the lateral lid cheek crease, and they love it. It looks amazing, and it helps so much for the crow's feet beside the toxin treatment. Nasojugal groove, some more examples. You can see that it's extremely rewarding and youthful. I use the cannula 22 gauge, and I enter from this point, like I showed you before. I go up. Just a second. All right. I go up in a vertical way and in a fanning technique, and I can go also from the lateral side, but this area I want to feel, not this area. And you can see how I solve without correcting the tear trough. Be aware that you have to protect with your finger on the inferior orbital rim so the product will not migrate to the lid area. And I do a layering technique, a sandwich technique, a lot of times with XXL on the deep part and XL on the outer part, or XL on the inner part and L on the outer part. So according to the pinch or the width of the male patient. Here is another example, very rewarding. You can see a nasojugal groove in an elderly patient with the mid-cheek grooves with 2 cc of XXL and XL. So one XXL deep, one XL superficial in a layering technique, and of course the other side. You can see here another example. Nasolabial folds. Well, this is one of the hardest areas to treat in male, although it's one of the most popular area. I use 1 to 2 cc of XXL deep and XL as a sandwich, or if it's a medium or not so severe NLF fold, I use the XL and the large, or the medium even superficially. I do some indirect lifting with XXL 1 cc per side, usually on the cheekbones, or XL to the mid-cheek groove. but beware of this indirect, because remember, with women, you don't have a problem. Don't treat the nasolabial, only do indirect. But with male, you don't want to overfill this area. So you have to treat the nasolabial. You don't have a lot of ways to produce lifting of this area, except of maybe some boluses here, like the MD code, but it not really helps. What helps is to do a direct injection, especially for these cases. I use cannula as well, or maybe needle for touch-ups. I use my biggest amount of material here in this triangle. I'm not aware of I'm not afraid of the artery because I go under the nostril. And here we don't find, in the peripheral area, we don't find the artery. The artery goes like this. So with my tip of the cannula, I do a very slow injection, or even with the needle, and it's on the maxilla, on the bone, and it produces a very nice lifting of the upper nasolabial, and it can help also the lower part, so you don't need a lot of material.
Udi, I would like to ask you something. Could you show the previous slide?
Yes.
One of the things that I find most difficult are the marionette creases. And it seems that in this case, you were able to completely erase them.
Well, I admit this is not my photo. This is a Vivace or stillage photo. But yeah, the marionettes are very rewarding also for female. I think that it's one of the most rewarding areas, like the tear trough in both male and female. I treat it a lot. I think in almost everyone from the age of 40, 45, even earlier, you can see this marionette, also genetics, but it's a very easy area to treat. I will show you how I do it. And but for the nasolabial folds, you can see also here, I show this picture because it's a man that already came to me with a round face. So I treated only the nasolabial folds, and I used 3 cc's, and you have to tell it to your male patient that you will need a lot of material for correction for this fold. For injecting there, I do subcision. I take the cannula and I try to break these fibrous bands that are medial to the nasolabial fold, and I try to spread that, to lift it like a pillow, or like like a balloon under the tissue. And without subcision, you can risk migration of the material. You can risk extenuating the nasolabial fat pad, which is more demarcated. And so be careful and try to do this subcision, but medially. All right. This is another treatment of nasal fold. Marionette area. Oh, jumped. Marionette area. I think that I don't have a picture of male patients that I treated, male that were consenting to show the picture, but I treated a lot, and it's very easy. And again, I shifted from a syringe that with a linear threading of thirds to a cannula of a 25 gauge, a short cannula, and I enter on the jowl fat. You will never risk bleeding here, because in the superficial jowl you have only fat. So I pinch it with my fingers like this. I place the cannula and I reach almost the corner of the mouth, and I treat it as a fanning technique. All this triangle, I can reach also the submental crease. I can reach also the chin. It's a perfect entry point, and it's very rewarding. You don't need a lot of material for that. I treat it with mainly stillage large. It's a very nice spreadability in this area. And again, I can always use another entry point from here and use a vertically fanning technique. And in the touch-ups, I can, if there is something left here, I can take a 27 gauge or even 30 needle, and with the medium or the rest of the needle, I can add this correction of this area. The chin and the jawline. And here we come to an area which is so important for male. And you can never estimate how it defines males. The chin augmentation, it's quite easy. You measure in the anterior view the width of the nostrils of the nose from one lateral nostril to the other, or you can use the space between the pupils on an anterior gaze. And that will show you, you can draw it, and then it can show you what is the width of the chin you want to achieve. And it's a very simple technique. And when you inject to the chin, you inject usually for 3 points, anterior point and 2 lateral points. I don't recommend to go with the needle laterally too much because it's painful. And keep in mind that you produce also a tenting lifting with this material. And usually you need a very thick hyaluronic acid, like the extra large, and not the XL, because hyaluronic acid, it's not like bone. It's soft. It produces a fatty chin if you produces a soft material. So go for the hard ones. Never mind, even if they will feel something hard in the anterior chin. You can ease it with extra large, a little bit superficially, but don't produce a fatty touching chin. And so this is for the chin area. And for the jawline, I use usually 2 points. And you can see one is the pre-jowl sulcus anteriorly, and one is a point that goes posteriorly. I urge you not to reach and not to inject here, because this is the jowls. You will add more material to a fat, sagging fat pad. So you have to keep in mind to inject until this point. So it will also lift this area a little bit, but mark your jowls and don't inject in them. But you can enter the same point or go backwards. In the angle of the jaw, keep in mind that you need to keep a 90 degrees angle or an acute angle, and we'll see examples of how Meir lose it and how we can restore it. Now, the principle for jaw and even for lifting jowls and jaws are, this is a very interesting slide because it shows us 5 points of basic principle jaw rejuvenation. The first point is the mandibular angle, as I showed you. The second point is the pre-jowl sulcus, as I showed you. And the third and the fourth point is the posterior cheek vectors, or the MP codes and the Juvidem, I don't remember his name. The Silva, what is the name of the allergan?
The Mayo.
The Mayo, sorry. The Mayo, yeah, just a blackout. Anyway, the Mayo showed this multiple points of lifting these vectors, so it helps a lot. But these are the main points. And when you have the classification in your clinic of the sagging, if it's mild sagging, use the first and the second point, it will be enough. If it's a moderate sagging, use the 4 points, 1, 2, 3, and 4. Also the posterior cheek vectors, it will produce some lifting. But if you have severe sagging and you try to inject this point in a different organization, first you inject the third point and then the fourth and the first and the second, it will help. I'm quite convinced that this case, the severe sagging, the very severe sagging, will need a facelifting, of course, because we cannot promise a good result. And if we do promise, we'll need a lot of material and, of course, every year renew it. Be careful when you inject to the jawline or the parotid gland. You don't want to create a sialocell. It's a devastating complication, and try to avoid deep injection. Do it slowly, small aliquots, and you'll be fine. So the jawline, this is a patient that came with a severe nasojugal groove also. He came with a kind of a pointed chin where you wanted to round it, to square the chin. he wanted also a treatment for his bad skin and severe acne scars. And I did here a injection for the jawline and some nasal Botox. I'm sorry for the quality of the picture. I treated him in some workshop, and then he sent me this picture. So, but we can see here that the angle of the jaw is more acute and it produces a better look, younger. I also treated the mid-cheek area and, of course, nasal Botox.
Udi, it's now 45 minutes, so...
this is the end of, this is really the end of the...
So I would like Dr. Raspaldo to, so please finish. Please complete your presentation.
All right, this is more photos. For the lips in males, don't be afraid to inject male for the lips, but don't inject in the Cupid's bow. Male are fuller laterally in the lips, so you can augment this area, but no filler in this Cupid's bow. Of course, you can do it, but try to avoid. This is the way. Sorry, this is the way I inject. I use the common practice of the thirds. I do the 1 cc of medium or special lips, and I decide whether to treat the frame or not. And I think it's a very rewarding, especially for a very bad skin lips, etc. So if you want to inject the lips, try to reach this goal. Don't try to over-inject. You don't want to end like this. And it's, also keep the ratios. And we can see here the last thing. It's very good and one and only, actually, most effective way to inject the barcodes, the blanching technique. Do you see the video?
Yeah.
And this is the best treatment for hyperdynamic wrinkles with Botox and in smokers. And again, if we can combine it with a toxin with 1 or 2 units when we do this mimicking. And it's a great, it's a painful treatment, but very effective. And I recommend it strongly. And final tips, just plan thoroughly, examine, spend half an hour, 40 minutes, 1 hour with the patient, and be sure that they will not expect a huge results, but they have to keep it realistic. And I, in my clinic, plan build-in packages for better results. So for instance, I don't agree to sell only 1 syringe of hyaluronic acid if he wants to rejuvenate his jawline. Or if I find that he needs some mesobotox or a radius, maybe, I produce a package of, for instance, a radius for the jawline or stylage extra large with mesobotox, and even I combine it sometimes with other areas. So it produces better results. I sleep better at night. I know that I did better, and of course, economically, it's worthwhile. And thank you so much, and hopefully it was helpful.
Thank you, Udi. So Dr. Raspaldo, please open your microphone. Great.
Yeah.
Okay. So please share your presentation.
I think you should instruct Dr. Raspaldo. You do an.
You have to stop your presentation.
Okay, so I will stop it. It's okay?
No, someone else is...
No, oh, wait, okay, now.
Okay, I've closed it.
Okay. Do you see my presentation now?
Not yet.
Ah, that's wrong. Zoom. Okay, now?
No.
I do it again, partager. That one.
Yeah,
okay,
great.
Now we see it?
Okay.
Perfect. Beautiful.
Okay. So we discussed yesterday, and I have only 20 minutes. I want to focus more on aesthetic medicine for male, but I will have a couple of slides for facial plastic surgery, because it's important to understand that we are surgeons. We know that we can do surgery, but many of our colleagues, especially in the conference, in 1,000 people, there are only 10% of surgeons. So I don't want people who can imagine we can do everything with just a filler or Botox. So I have some disclosure. I'm a consultant for VVC. I was a consultant for a while again, and that's it. So the plan is to talk about the anatomy and the physiological correlation, especially for male. And then when we talk about male beauty, we don't say a male is beautiful. We say a male is handsome. It means there is a difference, a big difference. Demand, expectation, psychology is very different in male. And I will share my experience I had in France and I have now in Switzerland, which is a bit different. Then a bit of technique and procedures, but in 20 minutes, I cannot cover everything. And maybe we can do another workshop if you want on specific areas. And then some showcase on medical injections more than surgery. So the first is when you look at the male face. So this guy is a top model. He's handsome and young, but everything that make the face of male attractive versus a woman, there are these four words: flat, squared, chiseled, and beard. If you have a flat face on a female, it's not as attractive. Nowadays, square jawline is more attractive for female, depending on the countries, but chiseled and beard female is not attractive. So why I talk about flat? Flat means flat brow, not a curved and convex. Eyebrows, it's better to have an eyebrow flat for male rather than female. Temples, they are not convex, they are flat, sometimes a little bit concave. And the mid-face. We talked yesterday how to inject the mid-face. If you over-inject the mid-face, and I'm sorry, you saw a picture of one of the presidents of the big countries in the world, he looks better, but he can be more puffy under the eyes, and that's not a male good appearance. So why square? Square because of the chin and the gonion. The chin has to be square, and the gonion, which is the mandible angle, has to be square. And this, nowadays, we can do it more with this strong and volumizer HA with a very high cohesivity, who says where you inject them. Chiseled means that we have on male more defined arcade. Arcade are the periorbital area. Arcade, eyebrows, orbital rim, the malar also. More you have a defined and chiseled malar area and jawline, the best you look. And people who doesn't have these cheekbones, but also in female, but male especially, it drops quickly and make the mid-face very, very sunken. So the male anatomy, you cover everything with you, so it's perfect. I just have to have a little bit of drops. So this on the left side, he's my colleague, he's a plastic surgeon from Nice. He's a great guy, but look at his muscles. The muscles are so strong, and I will show you how many units I had to inject his brow and corrugator. Then you see, so the bone structures are bigger, the soft tissue are heavier. It means that if you inject something, you have to think that this tissue are heavier on male. The ears, the nose, the jaw, it's ridiculous, but they're bigger. So if you want to make something small, it's different, and you have more to work on those areas. The skin, of course, is thicker and rough, and you have almost a third of the face is covered by the beard, which is good and sometimes bad, but more and more good at this time. So the aging process, is it as we say in French, un cauchemar? Is it a nightmare to become old with wrinkle, with a more aggressive face, or white hair? it's not that bad, because the square face with less visible line because of the thick skin is not that bad. And an older man looks more mature, so people look at this older man. This guy attracts serenity, comfort, reassurance, not only for the woman, but also for the family. And this attractiveness and this serenity means that it's a man you can trust. And if you look at Brad Pitt, okay, he was very cute, not handsome, very cute when he was young. But now with the beard, he changed his face, he's more and more attractive. So what I say is, the man with the wrinkle is still very powerful. And what else? What else is this guy? Look at him. And look at the picture. If you have the picture before when he was 20, he was not that attractive. And nowadays, because of this beard, you see the beard is very interesting. Look at this picture in black and white. The photographer put the lights on the center of the face, on the brow, the nose, the mid-face, and the chin. But the beard make the jawline very chiseled, and even is this guy, George Clooney, has a fat neck, you don't see it because of the shadow and because of this beard. So this is great, very great for male that we can cover with a beard. And then we have a new generation, as you said. We have what I call the metrosexual, or what we can say the new generation, the social media generation. And of course, we have another kind of male, which is the guy who has another sexuality. And this, I treat them like female, because they want something soft, they want something round, they want something plumpy, like the lips or everything. And this is male, but another way to inject them or to treat them. So the male demands, talking about the majority, not the new generation, not the feminized, but the guys like 40 or 50. So they want to look healthy, not so much younger, but to look, to have not a tired look. En français, on dit not to have an air fatigué. You mean that you look good. They have less expectation, in my experience. What I like is they are the own decision maker. I'm sorry for the lady who are linked in this program. I know you're a businesswoman, you know you can pay, you decide, but most of my clients, 80% of my clients, they have to refer to the husband or the boyfriend to know if they can do it or not. So this is something easier with a male. And by the way, when a man like me go for shopping, we go in one shop, we see one shirt, one pant, and we buy it. We don't think so much and we don't try many things. So it means that if you get the connection with a man, it's easier. And by the way, we are men, so maybe we understand better the man. That's why I think our female colleague, have better experience with female on these aesthetic medicines. So the problem is that you have more downtime. If you have a bruise and you're a businessman, it's more difficult. And that's why I think sometimes we have less demand. If you say, okay, I do your blepharoplasty or a facelift, you have to go out of job for 1 month to get it. Okay, so the new generation, they have new expectations. So those guys like Zach Brown, they want to look perfect. They want to look young. And even after 35, 40, they want to look young. They have more expectation. And this is what I call the selfie generation. So all those guys, you have to use a lot of technique. They also like laser. I don't do laser, but they like the cream. They like the laser. They like everything. They remove the hair, etc. So this is, and that's why we have more demand. And I like this generation because you can talk and you can offer, and also they talk. You know, social media, it works very well. It's like a, in français, you say boule de neige. You do one, they come by 2 or 4. So what about the technique? I do less with the male, and I do a step-by-step session. I don't do everything I can do in one session because I don't want to scare them to have more bruises or swelling, because the swelling for 2 or 3 days, it looks too big on the lips, on the mid-face, it's a disaster. And because it's painful and men were not so good regarding pain, I think that the lidocaine is very, very important with the use of gel, and I inject very slow. I use an ice pack and I inject very slow. to have time to use the lidocaine. Regarding the general concept, I use more volume because the skin is thicker, the soft tissue are heavier, so I use more volume regarding women, and the faces are bigger, so you need more volume. So it means that when you have to explain the cost, if you pay per area or you pay per syringe, you have to adapt your discussion, and that you have to say that if you need more syringe, of course it's more expensive. For Botox, I don't charge, I charge the same because I charge per area, but I use more dosage. Just a quick summary. What I do is most of the thing I do in Switzerland now are brow, forehead line, and eyebrows elevation and glabella. This is for male. Second indication are the mid-face. Not so much, not the labial fold, but what I call the nasojugul groove and the tear trough. But the tear trough, I'm very careful. I don't want to have a swelling on a male, also no female, but male also. It's difficult. And then more and more now we do nose and chin, because nose, if you want to do surgery, you have to block your program for 2 or 3 weeks. If you do an injection, so we can offer that. And the chin is more and more popular. So let's start with my colleague here on the right side. You see, this is an injection. So I show you first the result. This is 80 units. I started on that case on the right side with only 50 units, with only 20 units on the glabella, and I have to go up to 80 units because I had to use 40 units on the glabella and more on the brows, and this is the result. So what I want to show is that was a basal cell carcinoma of the glabella. So we see very well the corrugator, we see the procerus, we see the supratrochlear nerves, but what is important is to be careful when you inject there, especially on strong muscle and overdosage, you can have a diffusion to the upper eyelid. So I recommend to stay 1 centimeter away from the orbital rim. I used to inject 0.5 centimeter from the orbital rim. I use Botox. In the past, now I use more Azalure. But if you use strong dosage, and especially on the glabella, you have to inject 1 centimeter away from the orbital rim. Also, it's important, I like to lift the tail of the eyebrows on female. On male, it doesn't look that good. I inject myself, and sometimes I have these Mephistos, so I use these points to lower the eyebrows. This one unit of Botox or 2.5 or 3 units of Spaywood unit for Azalure on the tail of the, on the lateral side of the frontalis, just to block a little bit, to relax, not to block the frontalis. So on the mid-face, and that's the case I did for a study, and that guy had 3 cc. At that time, we were injecting a lot, and you see he was 60 in this picture, before and after, and I injected 3 cc per side, and that was for a scientific study. So he doesn't have so much a wrinkle or folds on the mid-face, but for me, it's over-injected. Nowadays, I don't do that on male. And by the way, we didn't treat the tear trough at that time. So that was in 2004. So for the mid-face, what I teach and what I do for my patients, I always inject in the safe triangle. The safe triangle is you put 1 finger on the inner canthus down to the corner of the mouth, the second finger down to the corner of the mouth and up to the lateral canthus, and of course the orbital rim is your upper limit. So this is what I draw in my mind, and on courses I draw on the face of the patient. Why? Because you see, medially to this line, medially you have the infraorbital nerve and the facial artery, so you stay away from those dangers, and laterally you are not anymore on the mid-face, you are on the malar area. So I like to stay there. And the last line you see in the middle, this horizontal line from the nostril to the tragus, I'll always inject higher than that. That's why I put a cross. I never inject there, because if you inject lower than the nostril, then you have a heavier mid-face and you make this mid-face and tear trough worse. So that safe triangle is there. And you see here, we have a mobile
try to lift
fat pad
this up
on the mid-face.
because this is
And this is
increasing the
sagging.
tear trough.
And then under this fat pad, you have the orbital the orbicularis oculi muscle. And then you have the deep malar fat pad. And in red is where we inject the tear trough close to the bone, under the orbicularis muscle. So again, superficial malar fat pad. On that case, I will use not a too cohesive gel, but I like to inject more very viscous cohesive gel, a volumized gel on a deep malar fat pad. And then this is how to lift the mid-face. And then I use a little bit of another HA on the tear trough if it's not enough. And that's also the safe triangle. I stay away from the facial artery and the angular artery. And you see here in beautiful dissection I've done in I think that was in China, no, in Singapore, sorry. You see the facial artery, the labial artery, you see the depth of those tissue and how deep can be the mid-malar fat pad. And this is where we inject. And we stay away from this artery, of course, because we have also connection with the ophthalmic artery higher, and that's the risk of necrosis and blindness. There's a labial floor. So this is where we inject, or deep in the deep malar fat pad, the green bolus, or on the bone under the orbital rim in blue, which is on the tear trough. And this is where the cannula. And the safe triangle again. Okay. So quickly, that's a video I've done for a course in London.
Yes.
Last June, I think. So you put the orbital rim upper limit of the safe triangle. Then you have another line from the inner canthus down to the corner of the mouth to create this V shape.
V shape with this triangle of safety.
By the way, I published that in the Journal of Cosmetic Laser Therapy in 2007.
And you don't inject there. You're always
so this protects the artery and the orbital nerve and the lateral part of the triangle from the lateral canthus down to the corner of the mouth. So then I want to show you something interesting. This is our colleague. I show the video, the picture, because he allowed me to show it, and he's very proud of it. This is Constantin Stan, the plastic surgeon from Romania. So I injected him in 2006 in Paris, and I used 3 cc per side at that time. And this is the injection, and the before and after with, you see the bruise, and that's the video. And that was, I think that was Voluma without lidocaine, but with a 21 gauge needle. So I put the finger on the orbital rim, the horizontal close to the orbital rim. And then you can go by fanning a little bit lower on the deep malar fat. Of course, it's safer to do that with the cannula, but at that time I was doing with the 21 gauge needle.
Did you also change your practice to cannulas?
I use the cannulas only for the tear trough. I use the bolus technique on the mid-face. Right. And this is on 3D. You see very well on 3D the change of the mid-face and then the nasojugal groove, the augmentation of this mid-face.
Le mec, il te montre ça.
Okay, so then, okay, that's the last one. Before I go for other details, I want to show you some experience I had because I was in a hospital treating HIV patients, and we were using this polylactic acid, and this is a guy with a severe deficiency on the mid-face. After 2 sessions and 5 sessions of Sculptra, you see how you can completely change the life of this. But this is in for, I mean, it's like reconstruction. Another case, and he was a friend of mine in the past, and he has this terrible deficiency on the mid-face. You can even see the zygomaticus muscle, and I use This is 7 sessions with Sculptra on the midface with polylactic acid. You see how you see the skeletization of the face on the left side, and a very good result because we pull all the tissue out and convex on the midface. And this guy also with severe deficiency, this one has 15 sessions. When you're in France, it's free of charge on the hospital. They pay for the patients. And this is him when he was young before the terrible disease. Okay. So now we're back to something more medical and aesthetic. This gentleman, he was a handball player, very on the top level. He broke his nose and his chin. So what I've done is I injected his nose with a filler and also injected his chin. So he had 2 cc on the chin and he has 1 cc on the nose. What is interesting on the chin is even with the beard, you can see the projection of the chin. And I said, why you want to change it? And he said, look at my, sorry, I won't show you then the, sorry. Oops. Voila. Look at the profile. Even with the beard, I said, okay, it's fine, but look at the picture. His chin is very long and flat. So with the injection with 2 cc, we make a new profile, completely new profile. And the nose also, we construct the bridge of the nose with HA. So I go back to the videos. And this is another gentleman. So I show every time on 3D what I can do with filler and what I can do with surgery, and they choose. And I say, okay, with the filler, it lasts from 8 to 12, 15 months. The surgery is definitive, and then you have to calculate the cost. You see on the 3D with Vectra, I have no disclosure with them. You can show how you can change the shape of the chin and the nose. So this guy had 3 steps. The first injection was medial because he wanted to remove his dimple on the chin and to project the chin. So that's session 1, anterior projection. So I put the needle right perpendicular to the chin. It's a bolus technique, and then I create a pyramid just to reshape that chin. And I'm still into the skin down to the bone, and I project the chin. So that was 0.5 ml. Now I want to inject the chin and to lengthen his chin. The chin was a little bit too short. You see he has a short face. You can slide on the bone and inject a little bit lower, and you inject to lengthen the chin. And then the step 3 is to feather the product laterally, not to make something too square. Okay. And that's the immediate results. So that's why male are very interested by injection, because you have no downtime, we know that. And the chin looks very square, depending how you inject. So if you have 2 injection points, you make it square. Okay, so we saw that guy, injections of the chin. So for the nose, I want to show you, you see what happened here. The nose was broken, so I put a little bit more hump on his nose, but the secret also, I lift the tip of the nose and I recreate the parallel lines that you see on the right side. He was broken, you see the V deformity because of the fracture. So the concept, I published that on the PRS, is to inject on the nasal spine and a cohesive product just to, like columellar strut, like a cartilage strut on the columella, and I start from the nasal spine up to the columella from the same entry point, and that creates like a pyramid, like a Eiffel Tower. So this is the paper on the PRS. You just Google PRS Global Open, my name, or Eiffel Tower nose lift, and you have all the details and the video for free, how to inject that. So for the injection, I'm very careful with the eyebrows and the Botox injection on male. I don't want to have or Mephisto or to drop too much the eyebrows, to keep some movement on the brow. I like to have more natural result, but it's more difficult because for male, we cannot over-treat, which is very difficult. And then for surgery, I will show you 1 or 2 cases of what I do, and then we can discuss. So rhinoplasty, bleph, and facelift. So that's a case of a trauma. This is what I have. It's traumatic noses. So this is typical broken nose, very difficult because you have to do septoplasty and then make a tip refinement and then remove the hump and do the osteotomies. I always do a close approach. Rarely I open the nose. It's 1% of my cases. And this from under the nose. The septum is straight, and then you put a graft on the columella. On this gentleman like that, what I did, I removed 50% of the alar cartilage through a transcartilaginous approach. I did an osteotomy laterally and a little bit of resection of the bump. You see how without any open approach or suture or nothing, just the removal of the alar cartilages, we can change the shape of the tip of the nose. And on the profile, I don't make them too short, or I don't open too much the nasolabial angle. Otherwise, you end up with a more feminine nose. And I like to keep a little bit of a hump, a convexity on the bridge of the nose. And that's his result. Shorter, but more adapted to his face. Right. The blepharoplasty of male, I show you a good case of mine and a very bad case of mine. So this is he's an artist, he's very famous and a friend of mine. So why I show the picture, because he doesn't care. So I removed the upper eyelid, maybe a little bit too much, but it doesn't show. I say too much because it dropped a little bit the eyebrows. And the lower eyelid, I remove 2 millimeters of skin and the eye bags, and that's the result. And this is a good result for a male, and doesn't look like he had a surgery. That guy, and that's a case of mine, he had too much resection. I did like a female resection, and the problem is he looks very odd, and I also removed too much skin and too much fat on the lower eyelid, and that's a case I did 20 years ago. And the problem is also he had a ptosis I didn't see before, and because of the fat and the skin, so now I remove everything, and you see more of the ptosis, and you see this too long upper eyelid, and the sulcus is too high. So probably I could now correct with fillers, but nowadays I don't know. That guy is in France. I don't know where he is, but this is a mistake not to remove too much on the upper eyelid. And I finished with this colleague. He passed away. He was an orthopedic surgeon, a very good friend of mine. He said, you can show that picture. And the funny story is, he said, I want to do it because my granddaughter, he's 4 years old, he said, Daddy, I don't like your turkey neck. And she was hanging on his turkey neck for ages. So he said, remove that. So I did a liposuction, a minimal facelift around the ears only, and an incision under the neck, under the chin, sorry, and I did a platysmoplasty and skin resection. Okay. So the typical male case I have in my practice, of course, businessman. Sometimes I have people from the media, some of the TV, or singer actors, but this is not the average. The average is an active 50-year-old man that needs a healthy appearance, active or retired. And here in Geneva, we have a lot of people who are not that old, but they have a lot of money, and they have a new life, a new girlfriend, a new or younger wife, and they have to look very good and healthy. I have also a gay population, and more I have now is this new social media generation. And this is, we have to learn, because I'm 59, I have to learn what they want. My son is 16, 17. And this guy, if we don't, like you, like Udi, you're young, you understand more this new generation, like me. Okay.
Not so young.
Yeah. So the last words are, I use more volume and more dosage of Botox on male, for sure. I'm very careful and conscious that it's more difficult because men, they are scared by the pain, and that's why sometimes they don't come. The thing is, I'm also concerned because on female you can use makeup and cover, and male you can't. So that's another point. So I'm open to all discussion. If people are interested by teleconference one-to-one, they can go on my website and I have an online training. Okay.
Thank you.
So thank you.
So I will show some cases, and if there's any question to Dr. Raspaldo,
de partager. Voilà, stop.
Anyone wants to ask anything?
Yes, I would like to ask Dr. Raspaldo if you can achieve those results also with HA, like the XXL or the XL instead of Sculptura. Because we don't have Sculptura in Israel, we don't use it a lot. Just wondering if you can reach those results.
So I don't use Sculptura anymore. That was in hospital only for HIV because it's expensive. We're using like 10 up to 30 vials of Sculptura in the hospital. So I don't use it anymore. Now what I do, I use Silage Double XL, I use Voluma, I use what's the name for Perlen now? Is Restylane Deep or something like that. So you need to use or the Teocia range where they have volume or something like that. And it works well, and I prefer because it's soft. Sculptura, the problem is it's very hard. You have your skin, it becomes like rock hard.
And what about Radius?
And Radius, of course, Radius. On the mid-face and the jawline, never on the nose and never under the eyes and never on the lips, of course.
Okay, gentlemen, so this is the first case for you. And I suggest that Udi will start first. This is a 38-year-old man, and he's coming to your office, and he feels that his face is tired, and he's looking for some change, some improvement. So Udi, a few words. What would you suggest? What would you offer?
But sorry, Meir, is this the after photo? Because I see
this is the before. No, this is the before.
So the blood stains.
No, it's a birthmark. It's a vascular lesion.
All right. So actually, like in
one of the options is to say you don't need anything. So that's always an option in plastic surgery.
Well, I think that what is the reason that he came for?
He feels his face look tired.
I see. How old is he?
38.
And did he notice any significant changes in the last few years? Do you have a photo of him younger? Maybe?
I don't have a photo here, but he says, I feel that, in recent years, I feel I look more tired. I'm less happy with the way I look. I look at the mirror. I don't like it. People tell me I'm tired.
All right. Can you switch to the anterior photo, to the AP?
Yeah.
Please. All right. So the way I diagnose is that I divide the face to thirds. I start in the upper third. I don't see his expression, so I cannot decide about neurotoxins. And I think his forehead is quite smooth. I don't see any static wrinkles. Maybe there's a little bit of sagging or excessive skin on the upper eyelids. Maybe I'll try to open up or treat laterally with the neurotoxin to increase the aperture a little bit more, maybe to contribute a less tired appearance. On the mid-face, and I think that's it on the upper third. I think that he has a frontal bossing, the hairline. Well, we can do something about the hairline, but okay, now I see the expressions. Yeah, but it doesn't have a very dynamic forehead, maybe in the glabellar region.
Okay, so you want to put a neurotoxin in the forehead?
No, now when I see the expression photos, I can do neurotoxin in the forehead.
Okay, so a neurotoxin, very quickly, Udi. Neurotoxin, what else?
And the mid third, I would try to add a little bit to his mid cheek area. I think that he has a lower third big proportion to the other thirds. And
Where do
if I
you
go
mean
to the,
here, Udi, here?
I mean here, not so much, maybe a 0.7 or 0.5 cc's per side.
Okay.
I would correct his upper third of the nasolabial fold with
Okay.
the lifter bilaterally.
Okay.
I would
What?
treat his lips. I think that his lower lip. I'm going now to the lower third. I think that the upper lip is a little bit thinner than what I should. And on the, I think that the jawline is quite vast and square and demarcated. I'm not going to add something, maybe a little bit to the chin. If I have the profile photo once more, you can see that maybe his chin needs some augmentation, but I'm not sure. I think that mainly the upper face and the mid face and the lips.
Okay, I'm just trying to mute. Someone is washing the dishes, so I can't find him. Sounds like him, but 1 second, I'll show you the, yeah. Okay, now it's quiet. So would you like to have a look at the lateral view?
Yeah.
Okay. I'll go up. Yeah, I have three quarters. Okay, Udi, great.
Yeah, well,
Dr. Raspaldo, what would you do?
Now I can see the jawline is
Very quickly, very short, very point.
Very quickly, we're not talking about money. I would just talk about what I think. I think he need an eyebrow elevation.
Okay.
With the toxin and corrugator and eyebrows elevation. And I will compensate a little bit the frontalis because otherwise he will have compensation with more wrinkles. This is number one. I will do on the upper face some temple injection with a filler to make the face more triangular because it's very flat here and then round is a very big face down there. So I will use a filler on the temple.
On the temple, okay.
Yes, asymmetry on the upper eyelid. The right side is lower than the left side, so I will use more on the right side. Then I will use a little bit of filler on his mid-face to just project and make it more convex. And last, it's important to treat, especially the lower face, the upper lip and the chin to make his more masculine. And if I have the budget in another session, I will say, okay, come back and I would like to do your gonion, your jawline.
Okay. Voilà. Where exactly on the jawline? Where will you put? Here? And
so on the chin first, the chin, to elongate the chin, and then not here, but on the gonion and the lateral part of the mandible.
Okay. So, well, I think both of you said pretty much the same. This patient was.
I agree about the temples.
Yeah, the temple was your idea, Dr. Raspaldo. I would be concerned about making him, a kind of Mongolian look. Don't you think so? With the temple.
Why Mongolian?
Well, Tataric, I would say, like very wide face. No.
No, I'm talking about half a cc per side. You don't over-inject.
Half cc. Okay, so it's very small. Okay, this patient was treated by Dr. Maurizio de Meir. Visited my clinic 10 years ago. He was not a celebrity at the time. He was just a beginner presenter. And what he did is, he did his lips. He did his lateral jaw, like here. And this is the patient before and after. So, it's interesting because the changes are really minimal, but I do think that something did improve on the right side. Do you agree?
Yeah, I would also consider neurotoxin for the masseter of the lateral jaw because it can maybe a little bit ease this strong, very wide mandible.
Okay. What he did, actually, he put filler on the lateral side, on the jawline. just to make it more more triangular, I think. And I think the main change is the lip, the upper lip. You see the difference?
Can I
Okay.
say something?
Yes, please.
As a heavy person with a round face, I will definitely do nothing for him if I see him in my clinic. As you can see, there is almost no change after injections. This is the type of a man that I will tell him, smile, only smile. That's it.
Okay.
Because he cannot change his
I wouldn't do anything, by the way. I think like Ron,
yeah.
I would tell him, you know, you look good. Maybe Botox, I'm not sure. But I'm not sure it's necessary. But I don't think he needs anything. That's my opinion. Ophir, are you
Meir.
listening to us? Yeah. Ophir, who is that?
לא, זה לירון.
כן, לירון, בבקשה.
תראה, הבקשה שלו, שלפחות מה שהצגת בהתחלה, זה שהנושא של לראות יותר, פחות עייף.
אחי, אנגלית.
תפתח את המצלמה, לירון, שנראה אותך. או שאתה עם פיג'מה.
The lateral holding he has, from my opinion, most of the central, but mostly lateral. In my experience, neurotoxins, I would maybe start, but advising that this is only a study to see if neurotoxin would help, but probably not. What I would do is an upper blepharoplasty with the access to the roof and try to anchor internally the lateral eyebrow higher. It's a male, I know. It's going to be less than female, but the only way that I see, I don't have experience with threads. Sorry, maybe threads, if somebody can comment about threads, but opening for him to look less tired. I don't understand why injecting the jawline or the malar area or the temporal area is going to make him look less tired. To my opinion, his eyes are the tired part, and to treat his eyes, I would probably opt for surgery or threads, but I don't have any experience with threads.
Okay, thank you, Liron. Anyone else? Ophir, are you there? You always have something to say about injections. He's gone. Anyway, Ron, did you want to say anything? No. Okay, so we'll move to the next case. Let's keep this one and this one and this one. Okay, let's look at this gentleman. He's 62, and he comes with the same complaint, and he says that he feels tired. He doesn't like his face. Everybody tells him that he has, his neck doesn't look so good. It looks old. What would you do for this gentleman?
I think that this gentleman has quite heavy sagging in all thirds of his face, especially in the neck area. And I can improve maybe a little bit with some fillers, the tear trough area, with Botox, maybe improving the periorbital area. But for the jawline, I don't see any other option than neck and facelift, because he will spend a lot of material, a lot of money, and will not see any results.
Okay, Dr. Raspaldo, what do you think?
So definitely, that's a case for a facelift with liposuction of the neck. And I'm very concerned with the eyes because he has a kind of exophthalmia, a double ptosis, terrible bags, and a scleral show. Keep the front face. So that's a very difficult case. I will do the facelift and the neck liposuction and see what's going on, if he's happy like that. And then I will discuss if he wants to go for surgery of the eyes. That's more difficult. Even if you do a transconjunctival bleph, you can have retraction because the scleral show. He has exophthalmia. If you do upper bleph, you can make this worse. So, well, I will be very concerned to touch the periocular area unless you do a little bit of fat grafting, or if he doesn't want to do another surgery or to put fat, maybe to do filler. But it's a very bad case for eye surgery in my hand.
Okay, if he tells you, you know, gentlemen, I don't want any kind of surgery, I just want injections, would you offer anything to him?
Yeah, I would do the mid-face injection and the tear trough, but minimal. And of course, I will do some relaxation, Maor relaxation on the corrugator and the eyebrows, just to lift a little bit the eyebrows. And can you show me the profile again?
Yeah.
Yes, her lips, the lips are a bit asymmetrical. I would do the chin injection that to make more masculine, and that's it.
Okay, Udi, would you offer non-surgical treatment?
Yes, I would. I think this also has quite marked asymmetry with maybe a facialis in the left side or a weakness of the facial nerve. So I can see it in the anterior photo. I agree with. Okay, I agree with Dr. Raspaldo for the indications of a little bit in the tear trough. I would do a facelift, I would do it with auto fat grafting, very little bit to this area and to the mid cheek. But with fillers, I just will disappoint this patient, and I can only improve maybe a little bit this periorbital area. Other than that, it's it's just throwing the money, you know. And,
yeah, what I did, that was like 12 years ago. What I did is a face and neck and facelift with fat grafting, and he was a tourist, so the only photos I have are 3 weeks after the surgery. I don't know what's the end result. You obviously can't say much about 3 weeks after surgery, so because sometimes it looks so great, and after a year it looks this thing. So, you know, for 3 weeks it looks good, and he was happy. Just a quick questions about the facelift incisions that you use in male. Do you use a pre-tragal incision, a retrotragal? Because I only use a kind of retrotragal incision, really retro, inside the ear canal. What is your opinion?
I use a pre-tragal because I have a lot of beard sometimes, and then it's not so nice to have the beard, the hair on the tragus, and it's more simple to go straight down there.
Yeah, Udi, what is your approach?
Although I'm also using a retrotragal incision. I was trained in Switzerland in La Clinique for this incision, and I think it's a good way to put the incision, as long as you put here a little bit, a few millimeters anterior to the tragus. You put a very easy and very fine stitch of 5 zeros, only to attach the dermis to the subcutaneous tissue, because it can produce roofing, and I like this depression, but I use a retrotragal incision as well.
Okay, Ron, would you do something else?
No, I think it's a very nice, very good result.
Yeah,
very good result.
Early result, I must say. It's early, so
early. Probably it will last, because
hopefully. Well, anyway, it was 12 years ago, so who knows what happened since then. That's the advantage of having patients from outside the country. Okay, this is another gentleman. This is a Vectra photo. I've seen Dr. Raspaldo that used the Vectra system. I have this system for about 10 years. I was very keen about the system initially, but then I found that the pictures somehow don't look natural. It looks like a kind of cartoon pictures. It's nice for to compare the before and after, but I feel that it makes things not so natural. So this guy comes to you, and he asks you, and he wants to improve his face. So he feels that his face is not masculine enough, doesn't feel that it's strong enough. And this is our last case for today, and I would like to hear both of you. And Udi, could you be kind to start?
Yes, so like in my presentation, we have to keep the golden ratio. So if you measure or try to describe the golden ratio on this male, we see that the vertical length is higher or longer, and I would try to avoid from this long face, and by injecting to the cheek area, by injecting to the, sorry, I'll start from above. So the upper third to the temple area, I think he has quite sunken temples. On the mid cheek, I will inject the medial cheek, a little bit also to the lateral cheek, a little bit. And I see here that he has a little bit of retrognathia. If I imagine a line from the nasal spine to the anterior chin, I see that it's a little bit retro, so I will augment his chin and do injection also on the lateral chin, at the pre-jowl sulcus, and of course the jawline, because I don't see the good definition of the angle of the jaw.
Yeah, okay, and this is Vectra simulation of a kind of liposuction and chin augmentation. He didn't have any kind of procedure, so it's just a simulation. It does look natural, but it's fake. So that's it. Thank you, gentlemen. It was very, very interesting. We've had some technical problems at the beginning, but Dr. Raspaldo, I want to thank you for joining us and for sharing your experience with the members of the Plastic Surgery Society and dermatologists and oculoplastic surgeons from Israel. Thank you so much.
Thank you very much.
Have a nice week. Thank you, Udi, for initiating this presentation. And thank you, everybody. See you in the next webinar.
Thank you.
Thank you. תודה רבה. Thank you very much. Good night.
So thank you to invite me. I'm very happy, and I hope I can come on real in Israel, because I've never been in Israel.
Oh, you should come.
Yeah, it's crazy.
Okay, thank you.
Bye.
Thank
Good
you.
night.
Good evening. Bye-bye.
Bye.
Thank you.